We're now going to be taking a look at the healthcare system from a different point of view, a different angle, and specifically it's the question of systemic racial inequities that we're seeing so obviously in our hospitals and in certain cities, and actually across the nation. The pattern is just is undeniable and has to be discussed. I also want to bring into this conversation Dr. David Hayes-Bautista. He is the director of the Center for the Study of Latino Health and Culture at UCLA. And Dr. Hayes-Bautista, I want to read something from the New York Times recent reporting. They did a breakdown on CDC data. They said Latino and African-American residents of the US have been three times as likely to become infected as their white neighbors, according to new data. This data looked at detailed characteristics of 640,000 infections detected in nearly 1,000 US counties. And also Black and Latino people have nearly been twice as likely to die from the virus as white people, the data is showing. Dr. Hayes-Bautista, do we know why?
Yes, absolutely. Talking about fumes, these communities, these populations began with the fumes of American medical care. For example, since March, 5.5 million people have lost their health insurance because they were suddenly unemployed. This in the face of a pandemic. Then, if a Supreme Court suit is successful, being brought by a number of Republican governors, about 20 million people will lose the insurance they gained under the Affordable Care Act. So right in the face of the pandemic, 25 million people could conceivably lose their health insurance. That is a problem. Secondly, these communities live on the fumes of the provider supply. We've been doing a lot of work on the Latino physician shortage. And to make a long story short, the Latino physician supply is so great that at the rate that California medical schools graduate Latino physicians, it will take 500 years to make up the shortage for the year 2015. So imagine, Senora Gomez comes in, she has a high temperature, she has a dry cough. Well, Senora Gomez, please take a seat and the doctor will see you in 500 years. This is a problem. It turns out that this is not an issue of affirmative action either. Black Latino medical students, when they graduate, are far more likely to practice in the shortage areas. In fact, Latino medical students, when they graduate, are 25 more times more likely to practice in a heavily Latino shortage area and to speak Spanish. And before anybody gets on me about speaking Spanish, medical services have been provided in Spanish in California for 251 years. California came into the United States as a bilingual state. Spanish is just part of California. It's part of the West. It's very important. Thirdly, is the issue of essential workers. When the pandemic started, and I'm on the board of a hospital in East LA, people were worried about physicians and nurses, as we have just heard, making sure they had sufficient PPE. What we forgot is there were other essential workers that were just simply off our radar scope. For example, farm workers who plant and harvest the food that we all eat, the packing employees, the slaughterhouse employees, truck drivers, grocery store workers, auto mechanics, attendants in nursing home, the non-medical staff in hospitals. We left them off the record. They didn't get the PPE for nearly 2 months. Meanwhile, they were being exposed to coronavirus. So those three things are kind of the fumes that particularly Latino, African-American communities had to start with back in March.
Dr. Ozuah, you wrote an op-ed piece recently in which you described systemic racism as a plague that you have not yet been able to overcome in your work, while you have actually been more successful in dealing with literally medical plagues. But I want to come back to this question of systemic racism in the healthcare system, and adding to what Dr. Hayes-Bautista has just portrayed as an inherent problem of who's doing the kind of work and being exposed. But more broadly speaking, before COVID, would you have said that the healthcare system itself has a problem with systemic racism?
Well, I think that health outcomes have a problem with systemic bias. And let me just explain what I mean. When you look at the determinants of health, health services are only one of those, and actually is number 5 of the 5. The first is genetics. Okay, we can't do much about that. But the second is individual behavior, which often has to do with education, whether you smoke or not, you have a firearm, safely or not. The third is the physical environment, overcrowded housing, etc., pollution. And the fourth is the social environment, poverty, economic privation, food deserts, lack of outdoor space. So when you look at all of those lead to, for example, in the Bronx, an obesity rate that is so far higher than most places in the country, and therefore a type 2 diabetes rate that is much higher than the rest of the country. And nearly half of everybody who died at Montefiore with COVID-19 had diabetes as an underlying condition. So you can see how these factors come into play. And then, of course, when you throw in access to healthcare, which is the fifth, but if you've got certain kinds of insurance, the reality is that if you have Medicaid as your insurance, your access to care is more restricted and limited than somebody who has commercial insurance. So all of these factors together conflate to create a disparity that I think COVID-19 simply ripped the bandage off of that sore.
Dr. Hayes-Bautista, I'm assuming you agree that the Band-Aid was ripped off of something that was already there. Does the experience of COVID-19 give us direction to what we can do to fix things in the future?
Oh,
in other
definitely.
words, seeing the problem exposed, do we see solutions that are more coming into focus more clearly?
Oh, definitely. And particularly as we deal with the healthcare system, to begin with, we could do what almost every other country has done, every other advanced industrialized country has done, which is ensure universal access to medical services when they're needed, either through insurance or through health service systems. Everyone else does it. They spend half of what we do on healthcare. It seems to me if Japan can do it, if Germany can do it, if the UK can do it, probably we can do it, and it might be one of the best things for our economy. Secondly, we need to make sure that the providers in this country look like America 2020. Right now, they look like America about 1970. And this is important, not only for practice and for language, but also for research. I'm a researcher. And the research only follows the questions that an individual poses, an individual researcher. And we have left the questions that are some of the structural issues out off the table in the research lab. So
could you give an example of that kind of thing, like really zoom in on how the question relates to who's asking the question, and therefore you're saying certain questions don't get asked?
Surely, and we can tie it directly into public policy. The idea that once the pandemic began, that we would shelter at home, you'd commute to work on your laptop, your children would stay at home, they would have sufficient screens and bandwidth that they could actually do their lessons. We didn't bother to look at farm workers. Now, when you have children of farm workers in the research lab, they might say, well, wait a minute. Farm workers, they work shoulder to shoulder. They supply the food. Isn't that pretty important that we also consider them to be essential workers? And it can go to clinical issues, to basic sciences research. But we need to have more diversity in the labs, diversity with voice in the research labs, to be asking questions that are appropriate for multicultural, multiracial US society of 2020. We're still asking the questions of 1970 when we were a lot less diverse.
I just have a question come in. Digital health solutions have taken off during, oops, I lost the question. Can it be sent back to me by any chance? It was on my screen and it disappeared. Where do you see digital health solutions factoring into health disparities? Dr. Ozuah, do you want to take that one?
Yes, I think as was being alluded to by Dr. Bautista, digital health, there's no doubt that we're going to move much more towards telehealth and digital health. We moved nearly 80–90% of all of our non-COVID patient interactions to digital. However, it poses the issue of who has access to enough bandwidth, who has only one laptop or desktop in the home. And if the child is on it doing schoolwork, how can grandma access her doctor? So all of those things come back to the underlying disparities. And I think that digital medicine is here to stay, but there are disparities still in access to it.
Dr. Hayes-Bautista, what about you on the question of digital medicine? Does it in any way address the gap that you've been talking about in terms of representation among those who are actually providing medical care? It would seem to me that it doesn't.
Well, it could. Let's put it like this. It could. It is a tool that could be out there. In fact, we released a white paper on the lessons we learned from COVID, telehealth, and Latino patients. And we are going to be releasing shortly one where we've taken the learnings from telemedicine into teledentistry. That Latino dentist shortage is so bad that it makes the Latino physician shortage look good. But we think rather than waiting for 500 years, why don't we use the technology at hand? And yes, that means we need to ensure broadband access at sufficient screens, et cetera. But that would be a lot quicker and easier than waiting for 500 years to graduate enough Latino physicians. So yes, we need to use all the technology that we can, think out of the box. And again, if you have more diversity on the team thinking the solutions, the more likely we're going to understand, oh, you need better bandwidth in the barrio.
One last question to you. It covers the topic of individuals being frightened to go to seek medical care right now. And again, my wife, who's a physician, says that she thinks she treats a disparate population. One is quite well off and one is more socioeconomically challenged. And she says that people in the second group are not showing up. And she thinks it's out of fear either of infection or something else. Is that fear a real thing?
Oh,
and is there, talk about it and how to overcome it.
It's a very real thing, because remember, particularly in California, the industries and occupations that are essential, like farm working, meatpacking, are largely filled by Latino workers. And they are scared to death. They can see their coworkers getting sick, dropping out. You've seen this in the Midwest, that the meatpacking plants have really become threatened by the illness and death of their workforce. They are scared to death. Plus, if they don't have insurance, up until recently, you might be asked to have to pay for a test. How are you going to pay for that if you don't have a regular source of care? And there is a lot of fear out there. They can see things happening, and it's happening at a higher rate, 2 to 3 times the rate of the non-Hispanic white population, and very few places to turn. These communities are really running on fumes to begin with.
All right, a lot of challenges and a lot to think about. I want to thank both of you, Dr. Ozuah and Dr. Hayes-Bautista. Thanks so much for joining us.